Hey, good morning. A live look at downtown Kansas City this morning. Did you know that minorities and black women make up for as many as 15% of the population in this city alone? But even living in a big city, many black women don't get the care they need to keep their babies healthy. The community has tools out there for you. Open mics with me, Dr. Steve Stites, starts now. Hey, good morning. It's Wednesday, April the 13th. Thank you for joining us here on Facebook, YouTube, and Twitter. Coming up at 8:25, we're going to talk a little bit about caffeine, but we may not talk as much because though there was some promising studies, there's also some information that suggests that's not the best therapy for ADHD. At 8:15, Dr. Hawkinson's going to join us with the latest COVID count, plus the COVID headlines, and there's some talk to do because we've got some new information breaking this morning. But first, the number of black women who died during or after childbirth has surged. What's being done to reduce that number and make sure their babies and their moms get the care they need? Get your questions sent to us on YouTube, Facebook, and the Medical News Network. You'll find links to those right here on your screen. First this morning, beloved comedian and actor Gilbert Gottfried died yesterday at the age of 67. He had a rare genetic disorder. You probably have never heard of it. Jess joins us now from Studio B with more on what that is.
Dr. Stites, good morning. Well, many may remember Gilbert Gottfried as the voice of that yakking parrot from Aladdin, or his stand-up comedy routines, or maybe the Aflac duck. Gottfried's publicist revealed yesterday that he suffered from a rare genetic disorder called recurrent ventricular tachycardia due to myotonic dystrophy type 2. That is a mouthful. And so we have brought in Dr. Madhu Reddy. He is a cardiologist here at the health system, and he's going to join us just to help us better understand exactly what that is. Good morning, Dr. Reddy. Could you kind of help us break that down so we can all understand what Gilbert Gottfried had when he passed away?
Yeah, good morning, everyone. So Mr. Gottfried, he unfortunately had this rare condition called myotonic dystrophy type 2, which is a proximal muscle weakness, a progressive weakness of his muscles, which is a neurological condition, and it's a genetic condition. Unfortunately, about 50% of them, the patients who have myotonic dystrophy, have cardiac involvement where the heart muscle gets weaker and they can have dangerous arrhythmias called ventricular tachycardia. And Mr. Gottfried unfortunately had ventricular tachycardia, recurrent ventricular tachycardia that could not be fixed, and he died of the ventricular tachycardia as a consequence.
Dr. Reddy, so just to clarify that, can you develop it, or is it only passed on genetically?
So there are many ways, many reasons for having ventricular tachycardia, but what he had was related to myotonic dystrophy, which is genetically, it's a genetic condition. It's a rare one. It does not have to happen in many members. Sometimes it happens all of a sudden in a particular generation. About 1 in 2,500 people have this mutation positive, and not everyone who has the genetic mutation have the condition. And there are many different forms of it. And he had the type 2 form, where ends up having the clinical symptoms much later in age.
So pretty rare, but can you test for it early and maybe try to get ahead of it?
Unfortunately, by the time we figure out the symptoms are so subtle that by the time we figure out they have this condition, most of the times the diagnosis is delayed by almost a decade. And early diagnosis is obviously very important if we can. Unfortunately, the symptoms are so subtle. We have proximal muscle weakness, generalized weakness, and we end up looking for many other conditions. And this happens to be checked much later because it's not the more common condition.
So how long can somebody live with it? What's their quality of life?
Unfortunately, the quality of life is impacted significantly because it's a progressive muscle weakness, and walking, getting up, and doing day-to-day activities gets progressively difficult. One of the most common complications is actually pulmonary or a lung-related problem because the skeletal muscles of the chest get weaker, and many patients are unable to breathe, and that's actually the most common reason why people die of this condition.
So really no treatment. Are there any signs that you should look for, any conversations you should have with your doctor?
When you have progressive weakness in your muscles of your legs or arms, or having trouble breathing, I think that's kind of the earliest symptoms that that people have, especially when you're having difficulty to get up from sitting down position. That's probably the most common first symptom that patients have with myotonic dystrophy. From the cardiac conditions, it's a rare thing, and once you know the diagnosis is there, we monitor for looking for cardiac complications.
Dr. Reddy, thank you so much for joining us this morning. We appreciate your insight and helping us better understand exactly what that is. Dr. Stites, I'm going to send it back to you in the studio. And just, it's always so interesting when a celebrity passes away. At least it sheds light on something that people, start to learn more about or have a better understanding for, right?
Yeah, I think it does. And I think that's a good point, Jess. And at least there's an opportunity to educate. And I appreciate Dr. Reddy being on the program. At 62, I'm going to say that 67 is not old at all. And I don't know that I've treated many patients with this, Dr. Reddy. I take it that this is not uncommon in your practice. CF practice, most of my patients didn't live to be 67 or 62. That's changing now. But you must see a fair number of people with this disorder.
We do. Once we have the diagnosis, because the diagnosis is made, by neurologists. Once the diagnosis is made, we have this criteria of monitoring these patients frequently. The most, as I said, 50% of the patients end up unfortunately having some cardiac rhythm problems, and we monitor them by doing routine EKGs, echocardiograms. Unfortunately, sometimes we cannot predict the progress of the cardiac conditions, and that's where sudden death from cardiac complications do happen.
All right. Well, thank you very much, and thanks for being on the program this morning. We appreciate that and appreciate education for all of us, and know what to do if they, which I assume is get a hold of your doc and get to work on what that underlying cause is. Speaking of numbers, 1 in 2,500 is a lot, but there are really some heartbreaking numbers around the death rate for black women that the CDC is talking about. Roughly after birth now, for black women, that number is much higher than it is for both non-Hispanic white women and Hispanic women, jumping from 44 to 55 per 100,000 live births. For Hispanic women, it jumped from 12 to 18 deaths per every 100,000 live births, and among white women, that is 23 per 100,000 live births. So it's significantly higher amongst African Americans. All right, joining me to talk this morning is Marcia. Did I do it right?
Yes.
Awesome. Look at that. And Houpe. Houpe. There you go. A nurse-midwife in labor and delivery, and Dr. Sharla Smith, founder of the Kansas Birth Equity Network. Good morning to you. Thank you for being with us, and good morning to both of you. Marcia, when you hear about those numbers, what goes through your mind?
Oh gosh, utter disappointment that we are still fighting this type of number, this type of statistic for black women, and then also determination as a clinician to help narrow and eliminate that huge gap.
Yeah, and that is a gap. Why are numbers so much higher for black women versus other minorities and other groups?
I would say that the numbers are higher because black women are dealing with more stress.
Yes.
Like the reality of the things that they're dealing with in this country is stress, and it's also that they're dealing with more issues as it relates to getting access to care, patient-provider communication, and really being able to seek the health care that they need. Also, in this country, there is a lot of discrimination happening, a lot of bias happening with black women being able to receive health care, but not only in the healthcare system, we're talking about in the community. What are some of those stressors for the black body in the community? And so we're seeing these disparities, and they're very stark and they're very disturbing because we're in 2022. So in 2022, we should see a change in these rates, but we don't see a change in these rates. We don't see a change in the maternal outcomes or the infant outcomes, and there has been nothing done in our country to really value black women to date.
Yeah, and actually there has been a change. They've gotten worse, right?
Yes.
Well, is that partly a COVID impact, do you think?
I think with COVID, it just kind of exacerbated the issue. When when we look at vaccination rates and, timing and access of care, I think it just highlighted the issue, but it's been here.
Let's return to that issue about the underlying stress, because I got to believe that's really a big part of it. And we know that African Americans in general have a higher stress profile in life, from historical racism, institutionalized racism, and current racism, and all the above, right? And then, in addition, more difficult economic circumstance. And during COVID, that's got to have added to the stress as well. So if I look at that, I think, this is a tough statistic to wrestle with, right? Because you got to look at that and say, that's not good, and we need to address it. You just can't have that number of people dying after birth.
Yeah.
Right. But I think the reality is what was happening before COVID, right? So before COVID, we saw these stark disparities, we saw the stress, and then COVID exacerbated those issues, but also highlighted some of the concerns we had. Additionally, Black women were a part of the working class, right? So that affected their economic stance in what they could provide for their families. Also, the level of stress and distrust with the healthcare system and with vaccinations. So we got to look at that trust as a reality of that stress. And then things were changing, right? It was a major change. So we saw this in Black women. Yes, COVID did contribute to these outcomes, but it just exacerbated it. They were already disproportionately affected. So COVID means that they were more disproportionately affected, and there was less access to health care. There was less access to the social services that they needed. There was less access to their families. Like, we weren't having that social support where mothers or caregivers could come in and support them after they had a baby, or come to their home to help them care for their baby. So there were major factors that contributed to these maternal outcomes during COVID.
So as you step back, and it is so great to have you both on the program to help address that, so thank you for doing this, because this is a tough subject today in our world today, as we see increasing polarization even here in the country. As you look at that, one of the things that strikes me is you are both Black women. There aren't that many Black women in healthcare in these kind of positions, and to your point, we know that folks do tend to trust folks who look like them better. So let's delve into that for just a moment. What is that like for you? And what are the voices you hear out there? What can we do about getting more Black women into healthcare to help address that disparity?
I had a patient a couple of weeks ago who came in for a prenatal visit, and she came in with her partner. It was her first baby, and I walked in the room and you could see her eyes just kind of light up and get big. And she, I sat down, introduced myself, and I said, "Hi, I'm Marcia. I am one of the midwives that's going to be taking care of you." And she said, "Can I just ask you or tell you two things?" And I said, "Oh, absolutely." And she said, "Number one, can I tell you how happy I am that I have someone that looks like me?" And then she said, "Number two, I don't want to die." And so I think we have, as a clinician, I had to step back and go, not only do I know about these disparities, but we have these Black women that are carrying this and coming into their prenatal care thinking, do I have someone here working for me and helping me? And I think as a provider and a clinician, we have to be purposeful about listening to our patients, and purposeful on providing that evidence-based safe care for our patients, and then also purposeful about communicating with transparency.
I think that's true. I think we definitely need to increase the number of providers that look like the patients, but we also have to take time to educate the providers that don't look like the patients. And so there's an opportunity to do that. I think as a community engagement person that works with the community and talks to moms all the time, we have to realize that if you are a Black woman in healthcare, that you also shoulder a lot of the burden. Like, we carry a lot of the burden. We're a lot of the blame when it comes to that, because we're part of that system that they don't trust, right? So building that trust is really hard. But also that it's starking to us, and it's hard for us to carry that because they look at us as the responsibility, right? And so it's also hard for them to carry that, but it's hard for us. And then how do we change those things around, I'm a Black woman in healthcare and I really want to help you? And I hear all the time, I want a provider that looks like me, right? I want to talk to people that looks like me. I want someone that cares about me. I don't want to die from childbirth. I heard one of my community individuals said, "I dare not have another baby," right? Because of the things that she experienced during her childbirth. And I think hearing those stories makes me feel responsible as a community person, as a researcher, to really work on being a part of the solution. But also I carry the burden of whether or not I am a part of that solution every day. So not only are those women suffering, but those of us, because it's a minority of us in healthcare, are also carrying those burdens for those Black women.
Yeah, that's a big burden. I mean, there's a lot for everybody to carry. My wife's Black and has been since I've known her. I guess. But and I think she would say the same thing as an OBGYN, that she feels that, and she feels that from her patients most definitely. Well, talk to me a little bit about health insurance. That's a struggle sometimes for folks to get. What's the story? Tell me about that for African American women in our society.
So for health insurance, I mean, I know that we talk about the cost of health insurance, but the reality is in our state, if you're on Medicaid, you lose your health insurance shortly after having your baby, right? So there's no health insurance for you to really look at how do we address postpartum depression. There's no health insurance to really look at how do we address those outcomes that happen during the postpartum period, right? And so that is a major stressor for our moms. It's like, I can only have health insurance if I'm pregnant, right? And so what about that in-between period? What about the health of the mom during that time? And we haven't changed that. So I think we have to look at what's happening in our state around what do we do to extend this care to women. And there are some wins happening now that are coming up to extend that postpartum care. But how do we extend that care to women so that they have health insurance before, during, and after pregnancy? And so I think that is a major concern in not just healthcare costs, but in having healthcare insurance throughout the life of a mom.
That health insurance is important throughout our society.
Yes.
It's hard to access care without it. So, Marcia, where can people go in our community if they don't have insurance? Well, what's the choice?
Oh, there are, several communities as far as healthcare. We are actually contracted here at KU with a clinic where you can go and get health care that is either salary-based or based on Medicaid or things like that. So there's places you can go here in our community that will provide care and quality care for those who need it.
All right, that's really important, I think. Did you
And we
hit follow
can't
up?
forget about our health departments that provide care on a pay scale. We have our Moms Clinic, we have Vibrant, we have all the community, our clinics, our safety net clinics, our FQHCs, federally qualified health centers. So if you're looking for somewhere to go, then look for those federally qualified healthcare centers and our safety net clinics that provide care on a pay scale for you in your community. And there's a number of them in our community.
Yeah, I know on the Missouri side there's Swope, there's Casey Cares, there's I just had it. I was rehearsing the one in my head so I could name all three of them. Samuel Rogers got it. And then here on our side, then in Wyandotte, there is Vibrant, obviously, and they've done an amazing job in Wyandotte County. And you work some at Vibrant, I think. Talk to us a little bit about that experience.
It's a great experience. I love going to Vibrant. It is a clinic with that gives us an opportunity, like I said, to give that quality care to all patients. It is just a great population to provide care for.
Yeah, it's a great organization.
Yeah.
So. All right, I'm going to switch gears for just a minute. I know we're going to have some community questions, but first I want to get to Doc Hawk today. Welcome back, brother, and I guess I'm the one welcoming back.
Welcome to you.
I'm the one that was gone for a few days.
It's been a while.
Talk to me a little bit. How are the numbers this morning?
Yeah, numbers are good. Again, Steve, as you know, we've changed our. Last week we went to stopping the universal PCR screening for every inpatient admission. It took a little bit of time because we know there's some lag there, but yesterday we had 5 active inpatients. Right now we have 4 active inpatient infections, 1 in the ICU, 1 on the ventilator, still 39 in that recovery period. So overall the active infections, so these are people here that are here for COVID, so that's good.
It is good. It's a low number, and it gets back to kind of where we were last March when we got down to 5. We like that. There are some concerning trends, so let's talk about that just a little bit. We know that the BA2 variant is now the dominant variant in the United States, and guys, I think we have a couple of graphs to show if that's right. BA2 is about 72% of new COVID cases. It says don't panic. Here's the hotspot map. We've gone through this with you before, and you'll remember at the height of the Omicron or the Delta waves that map was like all purple. And you can see how much less purple it is. But a week ago, it was better than this. Look at the Northeast. You can see up in New York, New Jersey, and some of the northeastern states that there is clearly a trend here, and it's the rise of BA2. You can see the same thing out in Colorado and a little bit in Texas and Oklahoma and Alaska. If you go to the next slide, this is talking a little bit about the rates, and it looks at different states, and there are a couple of points I want to make out of this. First of all, you'll notice there is a slight uptick in some areas. It's really early, though, right? And hopefully the BA2 won't be a big wave in the U.S. But the other thing we note is, and the CDC has changed, and I think it's the right change, there is so much wave after another wave after another wave. What we really have to focus on is hospitalizations, because that's what's challenging our healthcare system the most. If you look at that last graph, you notice the hospitalizations rise later than do the rise in case numbers. What we are seeing, Philadelphia has now reinstituted their mask mandate. You say, why do they go back to a mask mandate? Because they're seeing a significant rise. And what they're trying to avoid is the rise in hospitalizations. What we know, and Hawk, we're going to talk about this for just a moment, in China, in Shanghai, they shut down the city. Yeah. But they've also had a population not as well immunized, a vaccine not nearly as effective, and they've had so many shutdowns before, they don't have much natural immunity. Yeah. In Europe, where much better vaccines, lots of spread in the historically, not seeing the rise in hospitalizations. Where will the U.S. land? Because theoretically, with the Delta wave, we weren't going to see that, or the Omicron wave, we weren't going to see the rise, but we did see a big rise in hospitalizations. So I think Philadelphia is probably trying to get ahead of that a little bit and saying, guys, we're seeing this big rise. Man, before we know it, we don't want to overwhelm our hospitals again.
Yeah, I mean, so many points here. That's important. I think if you look at Philadelphia, we know that New York had that masking for early school kids.
Less than 5, yeah,
preschool, because they couldn't be vaccinated. We know Philadelphia has done that. I think the next step for Philadelphia, they said they may move to mandatory vaccination cards should they get there. But I think that's just a point that hopefully now our elected leaders and our communities can pivot when those things do happen. And I agree with you. I think we have seen the headlines. New cases are surging, but hospitalizations are. But to your point, Steve, like we've said, hospitalizations do follow cases. We aren't as concerned as the cases, also because we know people are probably doing a lot of home testing or not testing at all, and so those don't get recorded at all. So we really need to use that hospitalizations as the bellwether. So I think that is important. But hopefully, with our vaccination rates, our up-to-date booster rates, our previous infections, all of those things, that population-type immunity, that will help. But of course, Steve, we do know also that there is that large population that is unable to be vaccinated right now, those children. And we know that children were particularly harder hit during this Omicron surge, the last Omicron surge, compared to before. So hopefully with this maybe increased or more population immunity, we can get to protecting the most vulnerable, those who aren't vaccinated, and of course the elderly and those with comorbid conditions.
You know, and I think the BA2 is certainly a new wrinkle we'll have to watch, even more transmissible perhaps than Omicron. And then there's a last slide I wanted to show. Guys, if we could pull that up. It's an interesting, it's something to just, before you get real comfortable with the idea that you want to have COVID, to have natural immunity, let's go to the next one after that. There was one that talked about hospitalization, the difference in hospitalizations versus, that's it. Okay, look at that second graph on the bottom there. First of all, you're 3 times more likely to spread or to get COVID if you haven't been vaccinated. And then the hard part is, look at the difference in deaths. Look at the very small bump in deaths in those who are vaccinated and the very large bump in deaths of those who were not fully vaccinated. You know, we talk about this all the time. Omicron was less severe in many ways than the Delta or the Alpha or the original variants. But at the end of the day, the death rate is much higher if you have not been vaccinated. And that's with estimates of half the country having had COVID now, Hawk.
Yeah, absolutely. And I think we always say, well, you know, look at different countries. We can't necessarily apply different countries to our country because the communities are so different. Locally, it's so different. Look at our country and look at our community. But I think we have real-world experience right here in our health system, Steve, exactly with that point. From January to March, where we had 110 plus deaths, only 4 of those were fully vaccinated and updated with their vaccination. So vaccination and update with vaccination is extremely important for keeping you out of the hospital and keeping you from mortality and dying.
Yeah, so we are going to continue our conversation now. We've talked to anything else you want to add about COVID today?
It's still here, but I think we're doing good.
One last thing. New drug comes out, some preliminary data yesterday looking at patients with more severe illness, suggesting that they can drop the death rate in half in people who are hospitalized and requiring O2 who have COVID. That is a big deal. Want to see the real evidence? It's only the preliminary press release by the company.
Yeah.
But the trial was stopped early by the Data Safety Monitoring Board. That's what happened with Paxlovid. That's really good news because that's science stopping the study saying, oh no, it's not ethical to continue because there's such a big difference.
And I think that's important too because Paxlovid, monoclonal antibodies, those are all before you get to that severe place where you need that oxygen and increased support. So that's a very important point there.
Yeah, I think that's going to be a really, really important deal to help us here in the hospital. So lots more therapy that we've had. That's great. We still go back to our original topic we were wrestling with earlier this morning. We return to our conversation with Marcia Houpe. Did I do it right? Marcia Houpe. Awesome. And Dr. Sharla Smith, founder of the Kansas Birth Equity Movement. All right. So, Dr. Smith, here at the health system, we use something called LIFT. Tell us what that means.
Yeah, so Dr. Angela Martin and myself teamed up to create a birth equity statement for labor and delivery, and the acronym is LIFT. And basically, it is to basically lift up our patients. But that sign, that post of that in our clinics or in our labor and delivery is going to not only impact the patients, but every provider, every person that is servicing a patient or providing care to that patient is going to see that sign, and it's basically saying that we're going to listen, we're going to be intentional, we are going to foster, and we are going to trust. And when you think of lift, you think of someone like lifting you up or embracing you or empowering you. And so it's a really great statement to just make that statement in labor and delivery to say we're committed to patient care, we're committed to reducing disparities, and we're committed to birth equity. And so it definitely took a collaboration between the OBGYN department and population health. And that statement was made, Dr. Angela Martin and I drafted that statement, but we took that statement to the community, to the Kansas Birth Equity Network, to get patient input, to get stakeholders input in our community, to really validate that statement, to make sure that it really meant something when our patients saw that we were committed to birth equity.
So studies show that students who have trained at diverse schools are more comfortable treating patients from different ethnic backgrounds from their own. It helps with creativity, helps with innovation. How do we get that to happen in more communities more often?
Yeah, so I think that we get that to happen by creating exposure, creating education and information and awareness, making providers aware of Black communities and getting that experience of dealing with Black communities. But one of the main important things that we're doing here at KU is that the OBGYN department and myself have teamed up to start a birth equity scholars track program, and that is a 2-year fellowship for OBGYN and family medicine residents, which really gives them training in our birth equity curriculum that we created, which is basically an anti-bias, anti-racism curriculum that highlights the voices of Black moms and dads, and it gives them 2 years to do research in birth equity based on the topic of their interest. It also gives them time to volunteer with a Black-led community organization that is working in maternal and child health, and then gives them exposure to policy making in the state of Kansas around birth equity. And then that second year, it gives them the opportunity to mentor those that are first year scholars. And so that is the way that we start to create that, is to create a program that really embraces birth equity and also trains all providers during those years of training to really embrace birth equity and to really see birth equity as what it is, which is shifting the blame for poor birth outcomes from women to healthcare accountability, system level accountability. And so they're really committed to that, and they're getting exposure and information and empowerment early on in their training to do so.
Yeah, that is a cool program. I have to say, congratulations to you all for doing that. So it must feel good to you to see people go through that.
I love it. I love it. Love it. Love it. Love it. Love it.
Talk to us a little bit about some of the experiences these folks are having.
As far, tell me.
well, like some of the people who are going through it, are people in this program right now?
Yeah.
So we have 5 in the inaugural class, but it just started in March. So there are 3 OBGYN residents and 2 family medicine residents, and we meet with them monthly for an hour, and they're committed to partnering with community organizations. So they're going to be meeting with them. They're going to be doing research projects with the research team, which is going to be mentor team that is going to be physicians and researchers. And so we're excited about that, but it's still in its infancy.
Yeah.
So we just started that initiative.
That is so cool, and I bet you would welcome to have people go through that program.
Absolutely. I just like my patient who was saying, I am ecstatic to see a person that looks like me to care for me. It's great to have those colleagues come through and experience.
Yeah.
Yeah.
And I think the goal of that is that not only will they say, I see a person that looks like me, but in those individuals that don't look like them, they're going to say, I see a person that cares about me,
Yes.
right?
Yes.
And so that's the goal of creating
It
birth
is a
equity.
big deal, and the mental health issues that have. I take it you guys get into some of the mental health part of that as well. A big deal. So April is National Minority Health Month. Tell us a little bit about that, team.
Yeah, so Minority Health Month is really a time to acknowledge minority health and to really embrace that in a way that we do that. Not only are we excited that this is National Minority Health Month, but the first week of this month is Black Women's Maternal Health Week. And so we're excited that this is a week to celebrate Black women, Black moms, Black birthing persons, and Black families in this Black Maternal Health Week to really acknowledge what we're seeing in our country and to change these disparities. So that's what makes, I think, this Minority Health Month so exciting is that we get to first start this month by really celebrating and acknowledging Black maternal health in our nation.
Yeah, I tell you what, I can't imagine. It makes you. It always made me so nervous when my wife was pregnant because I just want to have healthy children, healthy wife, right? Because and you get nervous about that, and this just the stress from hearing the statistics and the challenges that folks face. I mean, that's just got to add. I mean, right? This is cumulative, and it just kind of builds on itself. All right. Well, let's turn to see if there are any reporter questions today first. Jess, anybody?
Nope, we've got a couple
All
community questions.
Let's do it. Let's rock and roll there.
Okay, let's do it. So Emily says she's heard of some scenarios with women and pain, and it's often likely to be brushed off versus a man in the healthcare setting. Are there other unconscious biases that we try to understand in the healthcare setting? How can patients be advocates to help reinforce their needs in the moment?
Oh, that's a great question because, there's also pretty good data that African Americans do not get the same level of pain relief as white Americans when they're in the hospital.
Right. There's a historical perspective that goes to that. It's really that Dr. Marion Sims and the super bodies, right? So Black women were thought to be able to endure more pain than any other woman in healthcare. And so we see that most often being a bias. Even in modern day history, there are still some providers that believe that Black women can endure more pain than any other race. And that often happens in the community as well. But I think that the other biases that we see is whether or not Black women are the experts of their bodies, right? So we often hear Black women say, I'm not listened to. We saw that in Serena Williams. We see that in all social classes of Black women. And so the reality is there's this concern that Black women don't really know their bodies. They don't know what they're talking about, and so they're not listened to. And so the reality is that in that we have to believe that Black women are the experts of their bodies, and even if they're wrong, it is okay to check and make sure that there is nothing wrong during that process.
And I think here at the University of Kansas, we, with us having that lift, that statement, it allows us to really check and see, what are we doing? Are we listening? Are we providing care to everyone in an equal manner and safely?
All right, Jess.
And I do have a COVID question for Dr. Hawkinson. Joella wants to know, can you speak to the reasons why people jumped on board with getting the first booster last fall, but not so much for the second? I asked because I had to wait weeks for the first, but only a day for the second.
I think that's a multi-layered response.
Absolutely.
Go ahead. We'll tag team this.
That was my first response, Steve. It's probably multifactorial. I mean, I think there is COVID weariness syndrome. probably
Cows.
COVID vaccine weariness syndrome. There may be infection of those people who got boosted, so maybe they do have some natural boost that they don't necessarily need to run out and get it right away. And it's maybe just overall fatigue of, oh, now I'm being told to get another one. I think, again, you really need to take in your individual account and risk, and we know that getting that extra booster 4 months or more after that first booster, especially if you are high risk, being older age groups or comorbidities, can protect you, can increase your protection, reduce your risk of hospitalization. So, but I think just like you were saying, Steve, it's probably multifaceted, but I think a lot of it is probably weariness and just fatigue and just maybe mentally and emotionally done with the pandemic, even though we know the virus is still circulating.
Pandemic may not be done with us. A couple of thoughts. First, there's a lot more vaccine production going on today than there was before, so the ability to flex up and get that vaccine out there. B, the vaccine wasn't changed, so you already had a ready supply of it in the marketplace. Third, we know that 35% of 40% of Americans actually got the first booster. So we were already, that's about half of who got vaccinated for the first two series. And now I think this fourth booster is struggling more. What I'm hearing from my patients and colleagues is that, gosh, I'm going to wait until the fall. I've gotten already 3 shots. I don't want to get a 4th shot. I'm eligible for a 4th shot at age 62. I will probably get it in May, probably on this program, I'm going to guess. There you go, Jess. And just because I do believe in vaccination, and I think if you go back to that graph that talked about the difference in death rate between those who have been fully vaccinated and those who are not, it is a striking difference. So I think I'm going to err on the fully vaccinated side for myself, and I think you're still going to be eligible for another vaccine in the fall. I wouldn't worry about that. And then we still got to settle out. We don't know where this is going to land. People have asked me all the time, are we going to get one vaccine a year? Is it going to be one booster shot a year? I don't know. Because this is unique. This is unique disease. And what we have to remember is people say, well, it's not as good against Omicron. Okay, guys, look, it's still 75% effective against Omicron. What was the influenza vaccine percent effectiveness this year, Hawk?
16% of vaccine effectiveness.
16? We're still 75. It's hugely different. You don't want to have influenza. Trust me, you don't want to have COVID. I don't care if it's BA2, BA1, Delta, Alpha, the original, or Zeta, Beta, whatever, Pupa. I don't care what it is. You don't want to get it, and you're better off getting that vaccine. So we're still pushing it.
Dr. Stites, last question is for you, and only because you mentioned it off the top of the show, your concerns about studies and things that are swirling around about ADHD and using caffeine to treat that. We're going to talk a lot more in depth about that on a different show, but you mentioned it, so can you just put that to bed?
Yeah, we need a whole hour around the relationship between ADHD and caffeine and what we're going to do and whether or not caffeine is effective therapy. And a number of patients will say, gosh, caffeine helps me focus a little bit more. That doesn't necessarily make it an effective therapy. I think when you look deep into that, you got to get a little concerned that people are out there saying, drink a lot of caffeine, that's going to treat your ADHD. Probably not the best of approaches. We'll dig into that and get more focused on it in the future. But I'm a little nervous. People are out there saying there's this study that says, well, hey, caffeine may help ADHD. Oh, my God, that's the most uncontrolled thing in the world. I'm not impressed. Are you impressed by some of that? Yeah. At Pop Health people, I'm going to guess our team is probably going to frown on that one, so we'll come back to that. So, well, listen, let me just, a couple of quick last thoughts for you guys. Well, first of all, I want to ask you a couple more questions, if I may, just about do you think things are getting better or worse out there for Black women in healthcare?
Oh, well, I would say the data says it's getting worse. So we're going to see an increase in maternal morbidity and mortality from 2019. And so I would say that it's getting worse for Black women accessing health care, receiving quality health care, and achieving the outcomes that they want, being healthy.
Yeah.
We are aware of it. And now, our patients are definitely aware of it. So hopefully we'll see a turnaround. Hopefully.
It's got to be it just feels so conflicted in our society right now. You see, in some ways, the rise of Black women in really important positions.
Yes.
Supreme Court Ketanji Brown,
Yes.
Michelle Obama, and how well received she has been throughout the country. And then you step back and you look at what feels like a rising tide of racism. I don't feel as comfortable with my family going places I would have gone 10 years ago. And I look at that and I think, that's got to be hard. And then you see the statistics about how much worse it is. Do you guys feel that conflict? I feel the conflict. Y'all feel that conflict?
Yes. I feel the conflict every day. I have a black son, so I really feel the conflict in like what happens when he's out in the community, when he's stopped by a police officer. You know, how is he treated by others? He's tall. He is he's a teddy bear, but you know, he may present as a threat to some, and so we deal with that every day. It's like every day you think about what's going to happen, or if your phone rings and it's your child, if they've been stopped by the police, and it's just a continual thing. Like it has increased the fear amongst black women with children, and fathers who have black families are increasing. So that is a level of stress that we're dealing with on a day-to-day basis, and we're seeing these things. I think the George Floyd movement just kind of exacerbated and highlighted what we've been seeing for years, right? It wasn't anything new. It's just now that we were all in one place sitting still and we all had to watch it happen. But we have those fears every day when our children are not around us.
Thoughts?
We have a lot of work to do. We have a lot of work to do when it comes to decreasing and narrowing that gap. I am excited that here at the University of Kansas that we have Dr. Sharla Smith and have programs in place to help that.
I am too. I think this has been a great thing, and I really appreciate you guys being here this morning. We're going to talk a little bit about Mother's Day in just a moment, and I'll kick it over to Jess. But first of all, let me just hear final thoughts. First, Hawkeye.
Yeah, I would echo the statements of our guests. We know that, just as you said, there's been so much division. We know communities do much better when their populations are healthy, and we know that, especially recently with the George Floyd movement, as you said, there's been it seems like increased division. I would just continue to endorse and remind people, during this Holy Week and moving through, treat people with compassion, look at people with compassion. We've heard Dr. Nawalnik saying this. With social media and all that, it's so easy to dehumanize people. Just continue to look at them through the glasses of compassion and humans, and really help that whole cause. I know that we have FCHQs here in Wyandotte County. They do great work. I was fortunate enough to do some residency training at Swope Parkway. Such a great organization. These organizations provide great services and health care to our whole community, so continue to support them.
Final thoughts for you today, Marcia.
Oh, just the same. Like I said, we have a lot of work to do, and I'm excited that we get to work with great people at the University of Kansas Hospital to help narrow and eliminate those gaps, which is a goal of I believe all of us here.
Yeah.
Dr. Smith.
I would say the same. I would say that the University of Kansas is committed to birth equity, and that's a great thing. We're all working together to do that. If you want to get involved in the Kansas Birth Equity Network, which brings together diverse stakeholders to create solutions for Black maternal, paternal, and infant health. And then also for all of us to know that these individuals are human. So when we look at people, acknowledge that we have biases and deal with those, correct those, but look at individuals as humans and that everyone deserves the care. I would say the other thing is that Black women and infants are dying in our community, and we as a community have to come together and we have to do better. It is important to us that every Black woman, every Black birthing person, every Black man, and every Black baby lives to celebrate the baby's first birthday, and that means being healthy family structures in our community, and it should be important to everyone. So don't sit down, get involved, celebrate Black Maternal Health Week. Join us tomorrow night at the Black Company for a panel discussion with Kansas and Missouri stakeholders to really talk about these issues from 5:30 to 7. And just get involved and become a part of the solution and not the problem. If you're not doing anything, then you're a part of the problem. So become a part of the solution and get involved. Trust Black women, listen to Black women, and hear Black women.
Thank you. Thank you. Here's what I know, Jess, before I kick it to you to talk about Mother's Day, and I do need some ideas, by the way. my life's been an interesting journey because I had I grew up in Independence, Missouri. I went to a public high school, and it was all white. There was one black student who joined when he was a sophomore. I was a senior, and I thought, God, that's got to be tough. I went to William Jewell College, and Jewell is a great program in diversity now, but back when I was there, it wasn't all that diverse. And then I went to medical school, and I met my lab partner, who later became my wife, and so my life was turned upside down, and I think what I've learned more than anything is that one of the greatest wastes is that of the potential of human life and human dignity. When we don't allow people to achieve the best that they can, we all lose in that. How many people didn't get to play quarterback like Patrick Mahomes, right? I mean, come on, really? Is there somebody else you want besides Patrick Mahomes taking the ball from center? I don't think so. How many women didn't get to be a Supreme Court justice like Ketanji Brown is going to be? I look at that loss of potential, and I think, you see, that is a crime against humanity. Because at the end of the day, don't we all just want to get better? And better isn't by color of skin. Better is by what's in your heart and what motivates you and what helps you do good in this world. So let's do more good. Let's work together just to get that done.
Dr. Stites, I loved your panel today. What a great discussion. One of my favorite open mics for sure. Okay, so you met and married your lab partner, and then she became the mother of your children. So I have to put you on the spot. So do you buy Mrs. Dr. Stites a present for Mother's Day, or do you leave that up to the kids?
Yes, I leave it up to the kids, and I buy something for my wife, and she's going to get treated where she doesn't have to do anything that day.
Yep.
And actually, it's kind of become this Mother's Day weekend at my house, and so it's approximately a very big deal, as it should be, because you know what today is, Jess?
What?
Today is Sierra's birthday, my middle child. She's been on this program a long time ago, and as my wife has reminded me, it's her birthing day, and
Yes.
that was a hard birth. She had an epilepsy C-section, and so she deserves a lot of accolades for that. And I have a terrific wife, terrific mom, and I have terrific children. And so, to my now 30-year-old daughter, happy birthday! Love you, kid. And it's all about family.
You're right. Celebrating the mothers, the actual birther
Yeah,
on that day, the one who gave birth. So yes, happy birthday, Sierra. Okay, so, but I'm sure you need some good ideas. So we are asking our viewers to please send in, use this QR code on your screen right now, and send us tell us any good gifts you've received, and maybe you'd like to receive more of them, or if you have any good, unique ideas, please send them our way. You can send them through to the Medical News Network also. So send those in, and we'll share them here on our show. So thank you again so much for being with us today and having this great, important discussion. Don't forget, you can catch our shows anytime by logging onto Facebook, YouTube, and Twitter. Have a great day.
Coming up tomorrow on the Morning Medical Update, delivering a 1-2 punch to Parkinson's. There are all kinds of treatments, including boxing, to help those battling the disease. We talk about that, plus how llamas could help future Parkinson's patients. Check out these social media channels at 8 a.m.
I'm Alexis Del Cid on the next All Things Heart.
It's freeing. That's the best way to describe it. It's amazing to be able to just get up, take a car key, go out, and go.
The surgery that gave a local mom her life back, Thursday at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.